I'm a medical oncologist from Western Australia, and I also do translational research, so looking at the reasons why certain treatments work and don't work in certain groups of people. Part of that focus is working on Aboriginal Australians in Western Australia. So it's in Aboriginal Australians in Western Australia in particular, breast cancer is less common than the general population. And we've been looking at some of the reasons for that in addition. The higher mortality rates for Aboriginal Australians we've found partly relate to what has been studied in all the other states. That is, that they are slightly later stage, meaning larger cancers when they come to medical services. Also, they're more remote, and therefore there are slightly reduced sort of comprehensiveness of services. However, we've also looked at the biology of breast cancer in Aboriginal Australians, looked at the types of cancer they get and how they behave, and we found many differences there also. We found they get more aggressive types of breast cancer. We found they have more vitamin deficiencies that make the cancers more aggressive. And we found that the immune system interacts differently with the cancers and may cause further problems. And so there are many different facets to why there's a worse outcome, all of which we're trying to address. Certainly lower screening rates are a factor in the high mortality for the Aboriginal Australians, but they're just one factor. We do see that screening rates have been 15 to 20% lower over the last 20 years. There has been some success with both the Aboriginal and non-Aboriginal populations, so the screening rates for both have risen, but there's been this continual gap of about 15%. There are many things that are important to survival in Aboriginal Australians that really need you to be on the ground and collecting data from the patient as it develops. That's things like exercise levels and diets, which can influence outcome, and also the degree to which people are compliant or adherent to their medications. So we've seen both in remote populations and in Aboriginal populations that side effects are worse on some of the drugs for breast cancer, and we're seeing then there's higher rates of dropping off those drugs, which also will be affecting survival. Regarding policy and services for Aboriginal Australians, our data has found a number of actions we've taken. We actually identify where Aboriginal patients were most clustered, and we've put in 3 video chemotherapy services. One is in Broome, one is in Karratha, and then there's another one in Narrabeen, which is a smaller town towards the south of the state. And people can go to those services. We video link the oncologist to them, and they have a talk and discuss any side effects. And then there's a local chemotherapy nurse who can deliver their treatment, and that's saving them vast distances. The other thing we've got in the tablets and side effects is we're setting up telephone help services for people on tablets to both manage side effects and to make sure that their prescriptions are up to date, and to get those to people to try and get more people to the end of their tablet treatments and hopefully improve results that way also. It's certainly for Western Australia, in terms of culturally appropriate information, there are now culturally specific information sheets and telephone lines through the Cancer Council in Western Australia, addressing things from the Aboriginal perspective, both about different treatments such as chemotherapy and radiotherapy, and also separate resources for different types of cancer. And one of the things I think we could do better there, though it's a little bit tricky because it's fragmented, is to look at the language issue there. Most Aboriginal people speak English, but there are some that don't. But there are a number of Indigenous languages in Western Australia, at least 20, and so providing materials for each of those is difficult. That contrasts to New Zealand, where they have excellent Maori language materials in New Zealand, as there is a bigger population speaking that language here. Certainly, when we look at Indigenous people working in health service and in science as well, there is a dearth. We'd like to recruit more people. We in fact have a position for an Indigenous healthcare worker looking at expanding these services to remote areas, and we're still looking to recruit somebody after over a year now. So it is something that there's a short supply of. We do now have contacts in each of the states though, and we have 3 scientists, all of whom have Indigenous heritage, also working in the area, as well as 2 people in the medical service side of this problem. Well, I think it's quite easy to overlook things, and we make a lot of assumptions. We assume similarities when sometimes there are differences, and so some of these services need to be structured around certain aspects of the structure of Indigenous culture. For example, in some Aboriginal communities, the elders set times for men's and women's business, where men attend to business at certain times of the year and women at certain other times of the year. So for example, if you have your mammogram van arriving and it's a time when it's not women's business time, then you get a very low uptake. Whereas if you coordinate it, then you find a much improved uptake. Information goes with the sample to the cancer registry. And we're actually identifying recently diagnosed Aboriginal people, and we have central discussions of cases with a panel of experts, including people with Indigenous cultural expertise, and then we liaise with each person's local treatment team to try and devise the best plan, both with the information we've already learned from our research and also with further cultural input from experts in that field. Certainly regarding clinical trials, there does appear to be a lower rate of recruitment from the Aboriginal people. Because the rates of people are low and there's a very large sector of the community is remote, we're seeing that a lot of that relates more to remoteness than to cultural origins. A lot of the things we can do to address Aboriginal trial recruitment will be dealt with by addressing geographical recruitment. However, also it's important to have culturally appropriate materials to explain trials. And though we have materials on trials in general, we don't have anything as yet for Aboriginal or other Indigenous peoples.